Hi guys, welcome to the Aurora AKT 30-day challenge, day 3. We are 28 days now to go to AKT. Thank you so much to those who have done days 1 and days 2. I'm glad you got so much value from those 2 questions. Thank you for the comments that have been coming in, and thank you for putting your answers down, regardless of whichever stream you're looking at. So we're counting down the AKT until your exam, and every day we're going to hit you with a question, whether it's clinical, stats, or admin, looking at a high yield topic that people often struggle with, looking at some technique issues, and looking at a quick fire bit of knowledge teaching, just to keep that momentum going. Because I remember my own AKT, it was hard to keep going on a day-to-day basis, and hopefully this is going to keep things moving along. So let's go into the next question. 57 seconds. I'll just explain again. We do 57 seconds because when you average out the time that you get for each question in the real AKT, it's about 57 seconds per question. So I'm going to switch to the next slide and go silent for 57 seconds. Please do put your answers below, whichever stream you're watching this: YouTube, Twitter, Instagram, Facebook, or LinkedIn, and try and let us know how you're getting on. Let's go, 57 seconds. Okay guys, that is time. 57 seconds. Hopefully you put something down. So the answer here is E. So well done if you put E as an answer. This is a good example of one of the more side questions, I'd call it, from a cardiology point of view. When we think about cardiology, people tend to focus a lot on things like hypertension and angina and MI and AF and heart failure and those kind of classic things that we draw attention to in terms of guidelines. But one thing that often happens when you look at people preparing for AKT, particularly if you do a purely question bank focused preparation plan, you can miss a lot of the side issues out, the smaller conditions that come within bigger topics. So in cardiology, for example, things like pericarditis, myocarditis, endocarditis, cardiomyopathies, drugs that affect the heart, those kind of things are often missed, but they're all curriculum based. So this is all about inflammation of the heart then. So in morning clinic, you assess 3 different patients with chest pain. You're not sure of the diagnosis, but suspect in each case it's not an MI. Which of the following features does not match the potential diagnosis? So the first bit that might have got a few people is that does not match. When we do our live AKT courses, and we have a couple of these types of questions in the mock, people often miss this does not match. So you're reading at super fast speed. Which of the following features does match the potential diagnosis? So you start looking for the one that stands out, which one matches. Maybe it's, I don't know, Osler's nose, endocarditis, true, tick, move on. Now you may not be doing that today because you're not under that time pressure and that adrenaline rush that you often get in the real AKT, but that's something that I see quite a lot at our live courses in terms of the mistakes that people make. So does not match the potential diagnosis, sometimes harder to pick out the negative rather than the positive. So the first 4 are all true, they all match. So pericarditis, pain worse on lying flat, so it's improved on sitting forward, remember, so you just got to get that the right way around. But again, if you don't read one of these words incorrectly and you just make the assumption that pericarditis is something to do with lying flat or sitting forward, it can be difficult and it can confuse you. Myocarditis is usually a viral cause like pericarditis. It's usually viral Coxsackie virus is common. We'll talk about some of these things in a second. Endocarditis is one of the 2 classic findings on examination: your Osler's nose and your Janeway lesions. There's red kind of papules that can be quite sore. That's classic, so that's true. And then the classic ECG changing of pericarditis, your saddle-shaped ST elevation on ECG. We have a question similar to this on one of our mocks, I think, and it says saddle-shaped ST depression on ECG. But again, the fact that people see pericarditis saddle-shaped ST is almost enough for their brain to put that as true. So worth bearing attention to that. And then Garden criteria, staging is not for endocarditis. Garden criteria is for fractured neck of femur. And endocarditis, you have your Duke's criteria or Duke criteria, which we'll talk about in a second. So the answer here, which of the features does not match the potential diagnosis, is E. Just put a comment down below if you put another answer and let me know why, and also let me know if you missed the does not match, and at speed just look for the one which was true. So a bit about cardiac inflammation, and like I said, one of those kind of cardiac things that are not covered as much as the big ones in the guidelines-based treatments. So pericarditis, inflammation of the pericardium, the most common cause is viral, so Coxsackie virus, for example. If you get any questions that link pericarditis with MI, think about Dressler's syndrome, things like renal failure can lead to that as well. Let's move out of the way. The classic presentation then, sharp pain relieved by leaning forwards, like we said, worst on lying flat. May get a pericardial rub on examination, and that classic saddle-shaped ST elevation on ECG. How do you manage it? Treat the underlying disorder if you can. So if it's the reason why you think the pericarditis has happened, of course, treat that. But then analgesia, things like NSAIDs, are the mainstay of initial treatment. This gives a good point, actually, in terms of questions about management. So if it says, for example, what is the first line management? If there's something where there's an underlying cause, then one of the first things you should be thinking about is treating the underlying cause, whereas your medical brain might go straight to what's the first drug of choice. So it's really important when you're looking at management questions, what line of management are they looking at? Do they say things like, what's the first line of management? What's the first medication in management? What's the first drug management? What's the first investigation management step? And pay attention to that, because I see a lot of people lose marks on that in our mocks because they're not paying attention to what part of management's being asked about. Myocarditis, inflammation of the myocardium, again, usually viral, like Coxsackie virus again, but metabolic causes, connective tissue diseases can lead to myocarditis and linked to myocarditis as well. Very difficult to differentiate sometimes with an MI, classic symptoms like an MI, and if it is myocarditis, then it'd be treated depending on, again, underlying cause if possible. And then endocarditis as well. So one of those classic things that you learn way back in medical school, but may not see too much of depending on the rotations that you do leading into GP training. But that classic thing of new murmur plus fever, must think about endocarditis in the back of your mind. Lots of risk factors that you'd be looking for in questions if you're thinking of this as a potential answer. So underlying valve conditions, valve surgery, for example. Staph aureus, the most common organism, but there are lots of other bugs that can lead to endocarditis as well. And it can be a really vague presentation, and therefore it can be quite difficult to diagnose early on. Fevers, fatigue, back pain, abdominal pain. Again, of course, these things would make you think of lots of other presentation and conditions as well. So therefore have a very low threshold for suspicion, especially if the new murmur is there. And when you examine it, you have those classic things like any inflammation or infection, like fever, the murmur, like we mentioned, and then those things that are specific to endocarditis or things that should make you think about endocarditis, splinter hemorrhages, petechia in the hands and mouth, for example, clubbing of the nail, and then those two things like we mentioned, Osler's nodes and Janeway lesions. In secondary care investigations where happen, blood cultures, an echo to look at the heart itself. Like you mentioned, the modified Duke criteria would be used for diagnosis, and you have your major and your minor criteria for that. And management, of course, secondary care based, usually IV antibiotics, and maybe a need for surgery as well. So cardiac inflammation, a good example of something that's not often covered, or the detail of such may not be covered just purely through doing questions, and therefore some kind of background learning or needing reading is important. We talk a lot about our the need for a dual-based approach in AKT. So one of the ways that we can boost your knowledge alongside whichever question banks we're using is through our online courses. So we have three main online courses, clinical, stats, and admin. We have two bundles. We have a triple bundle, which is all three in one. And we have a double bundle, which is stats and admin. We'll be doing some stats and admin questions later on as well. So you can get 1, 3, 6, or 12 months. So if you are now 28 days away from AKT, then you can get the 1 month package now and use them right up to your exam. You can pause, rewind, go back. Teachings on the screen, similar to the slides that we've done. But we cover those gaps that maybe you don't get through by doing lots and lots of questions. So the clinical one, all the conditions, all the guidelines, all the treatments that you need. AKT admin has got all the administration and rules and certification that you will need, and then stats, the graphs, the calculations, the equations, the research, all covered. So it's something that's going to just build up your knowledge base so you can use it in the questions that you do. So if you go to the website aurora.medicaleducation.co.uk, click on the online academy, online courses, you'll see all of these there, and we'll put a link down below on whichever stream you're watching this. So hopefully you found today of some value. That's 3 done now. Put some comments in the a bit vanilla as to how much you've got out of 3, how many have you got. It's not about the number, it's about what you're learning from them, but it's always good to know where you are in terms of this stage of preparation. Hopefully we'll see you at some of our webinars coming up soon, and we'll see you definitely for day 4 tomorrow of the Aurora AKT 30-day challenge. Take care. Campus will pass.